Здравствуйте, мэм.
Hello everyone, please switch off your mics except lecturer, all mics should be switched off, please. Наля Рафаэльевна, как начнем?
Давайте.
Хорошо. А вы полный full screen не будете делать?
Буду.
Ага. С вашего позволения мы транслируем сейчас на YouTube, на ВКонтакте, на Facebook. Hello everyone, we have more than 40 participants and it's my pleasure to open summer school of the Department of Pharmacology, and Professor Nailya Rafaelna Mulatna will open this summer school with her lecture regarding to a very important topic of nowadays, COVID-19. Thank you very much for your participation, Nailya Rafaelna, and everyone who found precious time during vacation. Dear students, thank you very much. And let's start. Nailya Rafaelna, floor is yours. Thank you.
Okay, thank you very much, Rasul Salihovich, for introducing me. Hello, everybody. For those who don't know me, my name is Professor Nailya Bulatova, and I'm from the School of Pharmacy at the University of Jordan, from Amman, Jordan, and I'm an adjunct professor at the Department of Pharmacology and Clinical Pharmacology at the Bashkir State Medical University. Thank you very much for inviting me to give a series of lectures at the summer school. And I decided to devote these lectures to a very important topic, as Rasul Salihovich said, about the COVID-19. And of course, because I'm teaching pharmacology, I will devote my lecture to the pharmacological aspects of the treatment of this disease. And today will be the first lecture. I will be overviewing the disease with you. First of all, we call the positive organism of this disease the coronavirus. It belongs to one of the human coronaviruses, which along with influenza viruses, human metapneumovirus, respiratory syncytial virus, and rhinovirus are usually endemic, They're endemic, and they cause 15 to 30% of annual respiratory tract infections. Generally, coronavirus infections are mild in healthy adults, obviating any urgent need to develop treatments or vaccines. That's why until now, there was no need to develop any drugs or any vaccines for coronaviruses. However, more recently, the outbreaks of acute respiratory distress syndrome, which is abbreviated as ARDS, due to novel, highly pathogenic strains. There were several strains, as you know from the recent history. There was severe acute respiratory syndrome coronavirus, or SARS-CoV, which was observed in the Far East, like Vietnam and China and some other areas. Then there was Middle East respiratory syndrome coronavirus, abbreviated as MERS-CoV, and now we are dealing with the SARS-CoV-2. All of them have revealed the potency and danger of these expanding family of pathogens that have the capacity to kill many thousands of people around the world, if not geographically contained. As you know, the new coronaviruses, they are zoonotic infections, which means that they are transmitted from the animals. Bats have been implicated as the likely source of SARS-CoV-2. However, this is not very clear because some authorities believe that there is an intermediate host after the bats, the unusual animal called the pangolin, which was exported from Malaysia and Indonesia to China. Also, bats are believed to be the transmitters of the SARS-CoV and MERS-CoV. And these viruses in the bats are genetically similar to viruses of the humans, because they use actually the human receptors for the cell entry. SARS-CoV-2, the causative agent for the current pandemic coronavirus disease of 2019, which is, as you know, called COVID-19, and currently we are experiencing still the outbreak. It was first found in Wuhan, China, and initial analysis of the viral RNA obtained from the patients hospitalized in late 2019 revealed that it was 96% identical at the whole genome level to a bad SARS-like coronavirus. But as I told you, this is still debated. There might be intermediate host as well. A brief overview about the coronaviruses in general. The coronavirus belongs to the family of viruses that are very common in mammals, not only in the humans, as you could see. And the term coronavirus was coined in 1968 due to presence of the crown-like shape based on the electron microscopic studies. And then this virus was characterized by International Committee on the Taxonomy of Virus, and it belongs to the family Coronaviridae under the order Nidovirales in 1975. And this slide shows that the coronavirus group is a diverse group. It contains group 1, 2, 3, and 4. And the ovals show the coronaviruses which occur in the humans. We can see some of them are from group 1 and group 2. And the SARS-CoV, which we are dealing now with, are from the group 4. And they all, or most of them actually can cause the human respiratory tract disease. And as I mentioned, many of them have specific receptor binding site, which is the ACE2 receptor on the lung cells and not only on the lung cells. And usually this receptor is involved in the control of the blood pressure. The most known function of this receptor is the control of the blood pressure. I will go a little bit faster here. Maybe I will not go into details about the different coronaviruses. I will focus on the beta coronaviruses, such as SARS-CoV and MERS-CoV, that, as I mentioned in the past, led to severe fatal respiratory tract infections. And actually, the mortality rate was much higher than with current SARS-CoV-2. But the transmission was to less extent with these previous two viruses. And the experimentation results revealed that SARS-CoV and SARS-CoV-2, which is the current virus, would use the specific receptor that I have already mentioned in the previous slide. This is a slide showing a taxonomy classification of SARS-CoV. As I mentioned, the order and the family to which they belong, and the subfamily is called Coronavirinae. And as I said, we have different types or groups of viruses. And you can see that MERS-CoV belongs to lineage C, SARS-CoV to lineage B, and some of them also belong to the lineage A. As you are going to see in the next slide, the coronavirus has the spheric shape, with specific spikes on its surface. Within the virus, we have the single strand of positive sense RNA. This is the RNA within the virus. And it is similar to host mRNA, approximately of 26 to 32 kilobytes. And the defining morphologic features are club-shaped projections or spike projections from the viral envelope resembling the crown. That's why the name coronavirus. It looks like solar corona, actually, or crown, made of a highly glycosylated protein named spike protein, or we abbreviate it as S protein. And we have three other structural proteins in the virus, which are the envelope, membrane, and nucleocapsid proteins. And, here we have the details of spike protein, membrane protein, envelope protein, and nucleocapsid. As we said, in the core of the virus, we have the RNA molecule. Please mute your microphones. Kindly mute your microphones. All right. Please mute your microphones. Can I control this? I will try to control this actually. We have 100 participants. Wow, please keep silent. Don't speak while I'm speaking. It is interfering with the lecture. Okay, we continue our talk about the structure and the genome actually of the coronaviruses. The first 2/3 of the genome consists of two large overlapping open reading frames, or ORF, that encode 16 non-structural proteins. So far, we're talking about the 4 structural proteins, but there are also 16 non-structural proteins, including proteases, RNA-dependent RNA polymerases, RNA helicase, primase, and others that form the viral replicase complex, a platform which is used to propagate the viral mRNAs. So these non-structural proteins are all potential targets for therapies. Maybe in the future, we will have successful therapies for this virus, which would, in theory, work against all coronaviruses. And one of the next lectures, or maybe a couple of lectures, I will devote to investigational therapies that are currently under development. The remaining portion of the genome includes interspersed open reading frames for the structural proteins. Those that we could see, the 4 structural proteins, are encoded by this part of the genome, as well as a number of accessory proteins, generally non-essential for replication in tissue culture, but capable of suppressing the immune responses and enhancing pathogenesis of the disease, which is also an important target for the future therapies. This is the very informative slide overviewing the COVID-19 structure, its application and therapeutic targets. Because it is very crowded, I have split it into several parts. And now I will show you the left upper panel of the slide, which is discussing or showing the viral entry. Virus entry entails binding, as we said, to the target, which is ACE2 receptor on the surface of the cell. For example, this is the alveolar cell of the lung, which is the major target of the virus. Okay, the virus binds to the ACE receptor, its target, and is cleaved by the serine protease TMPRSS2, which is shown in green. This protease cleaves the proteins, which allows the fusion with the host membrane. We have the fusion and then endocytosis. And other cellular proteases, such as furin, shown here in the orange, facilitate pH-dependent entry through the endocytosis, as we discussed. And the predominant entry routes are cell type specific and dependent on availability of select proteases. So each cell, we have not only the alveolar cells that are attaching the virus, but many, many other cells in the body. Which cell will attach the virus? It depends which protease will be activated. The next slide shows that following uncoating and the release of the viral RNA, we have the uncoating after the endocytosis, and then we have the release of the viral RNA into the cytoplasm. And then we have the translation of the open reading frame 1A, which I have discussed, and also open reading frame 1AB. They produce the polyproteins PP1A and PP1AB. And these in turn are processed by the viral proteases to yield 16 non-structural proteins that we have already mentioned in the previous slides. And then we have the formation of the RNA replicase transcriptase complex, RTC, that uses the rough endoplasmic reticulum. Let me go back to that, sorry. Let me go to one of the previous slides to show this process exactly. So we have the translation, and then in the endoplasmic reticulum, we have the RNA replicase transcriptase complex, as I said, which drives the synthesis of the negative RNAs, and then the full-length negative RNA copies of the genome provide templates for the full-length positive RNA genomes. And furthermore, the translated structural proteins, we have the translated proteins now, and genomic RNA, they are assembled back into the new viral nucleocapsid and envelope in the ER-Golgi intermediate complex or compartment. And then we have the exocytosis, which is the opposite to the endocytosis. And the result of this exocytosis is the release of the new many new viral particles. And if this process happens in the particular cells, we have the cytokines released by the immune cells. Particularly important are interleukin-6, TNF, which is the tumor necrosing factor, and some other cytokines, which after being released cause severe inflammation. And as you know, this is referred to the cytokine storm. We have the potential strategies for the COVID-19 treatments, which we'll discuss in one of the further lectures. But now briefly, we can focus on the 4 major processes. We can block with the potential drugs the entry of the virus, or we can block its replication, or we can booster the host's innate immune response, or we can enhance the innate immunity. Innate immunity, particularly, we can interfere with the interferon. As you know, the interferons are very important antiviral endogenous molecules. Briefly talking about each of the potential strategies, the blockade of entry can be achieved by inhibiting the TMP-RSS2, one of the proteases that we have seen in the previous slide. So this is potential target of therapy. This may limit the infection, limit the penetration or entry of the virus into the host cell. The replication cycle can be blocked at several stages, and currently we have the drug remdesivir, which we'll discuss further, acting on this stage. And currently also we have several anti-spike antibodies, monoclonal antibodies that target the spike protein. And also the vaccines, they can work here by blocking the attachment through the spike protein and fusion. And also, in addition to the vaccines, we can achieve that using protease inhibitors in the future, which are very similar to the protease inhibitors that we use in the viral hepatitis C. Ribavirin is potentially investigated, but until now we don't have the great results. The interferon responsiveness is very, very interesting. It can be increased by interferon itself. And there are currently undergoing clinical trials investigating interferons, which are already in wide clinical use for certain diseases, including multiple sclerosis. Or another potential strategy is to induce the interferon release. We call them interferon inducers. Or we can repress the viral interferon antagonists. So all these treatments belong here to the 4th part. And also, in addition to the etiologic treatment, which means that we can target the virus, we can use also the pathogenetic treatment, where we can suppress the cytokine storm, which is one of the most life-threatening events during the COVID-19 infection. And we can block this cytokine storm by targeting the certain immune modulators, for example, interleukin-6, as I mentioned, and these are the main potential strategies. This is a kind of repetition. I may skip this slide, and rather I will show you the interference with the virus with the alveolar cells. This is the healthy alveolus. And this is the injured alveolus, where we have the rupture of the pneumocytes and the release of the specific inflammatory mediators. Some of them I have mentioned, cytokines such as interleukin-1, interleukin-6, and tumor necrosis factor by the activated inflammatory cells, including the macrophages and neutrophils. Now, the entry of the interleukins and tumor necrosis factor alpha into the bloodstream, leading to systemic inflammation. So severe COVID-19 is actually systemic inflammation with vasodilation, increased vessel permeability, leaking of plasma from the blood. This leads to the contraction of the alveoli, and then due to inward flow debris, destroyment of the surfactant, which is responsible for the patency of the alveoli, as you know, and this actually alveolar collapse and filling the alveoli with the fluid, which is shifted from the bloodstream, as I said, results in the breathing problem, fever, and multi-organ failure. So this is very brief and simplified way of pathogenesis. As you know, in infection process, we have always the immune response of the host. And when host comes in contact with the SARS-CoV-2, the spike protein binds to the host cell by ACE2 receptor, as we know, and fuses to the host membrane to release the viral RNA. And talking about the spike protein or the S protein, it has two protein subunits, each of which mediate distinct functions. The S1 subunit mediates the attachment to the ACE2 receptor. And that's why the S1 subunit is called also the receptor binding domain, or RBD, while the second subunit, S2, containing the fusion peptide and transmembrane domains, drives the fusion of the viral and host cell membranes, as we could see in one of the images previously. To be activated for fusion, the spike protein must be cleaved at two sides directly at the cell membrane through the endosomes, or both, and the sequence of the cleavage sites, one located at the border of S1 and S2 subunit, the other S2R within S2, just upstream of the fusion peptide, provides substrates for a variety of cellular proteases and determine cleavage efficiency. So it depends on the cell where the S protein will be cleaved. So the root or roots of infection would depend on the proteases available in different cells, as I said, and the protease cleavage sites. And this is demonstrated by the involvement of the cellular serine protease that we already know, TMPRSS2, which stands for the transmembrane protein serine protease 2, and activities of furin, and endosomal catepsins B and L in SARS-CoV-2 entry as well. Let me show this again to you on one of the previous images. These are the essential proteases that are determining the entry of the virus into the cell. Different cells, I repeat, contain different proteases. And such host proteases that cleave the S proteins are also potential targets for the antiviral drugs. And we'll have the detailed talk in one of the future lectures about that. A high rate of SARS-CoV-2 infections compared with SARS-CoV infections that was seen in Hong Kong and Vietnam previously may be at least partially explained by a higher affinity of the spike protein in the current virus for the ACE2 or its target. And the sequence divergence in both the receptor binding domain and cleavage domains in the spike protein between the SARS-CoV-2 and the bat virus highlight how only a few changes are needed to adapt an animal virus to a human or a host to human. As I mentioned, the body mounts an innate immune response, and among the human molecules, the interferons of 1 and 3 types are cytokines with critical roles in the innate immunity against the viruses. Not only against coronaviruses, but we are talking about the viruses in general. So the virus-infected cells induce and secrete interferon 1 molecules that bind to the cell surface receptor called IFNAR, while interferon 3 uses a different receptor, and binding to the specific interferon receptor triggers the JAK-STAT signaling. JAK-STAT is the abbreviation for the Janus kinase signal transducer and activator of transcription signaling pathway. And this pathway switches many antiviral genes. So it offers the protection against the viruses. And the interferon stimulated genes are then transcribed into the RNA and translated to proteins that suppress the viral replication and the spread. So this is the role of the interferons, which are induced, normally should be induced by the viral entry into the cell. Like other human coronaviruses, the SARS-CoV-2 can at least partly evade innate immunity. So this is the problem. The virus tricks the immune system, so it gains a foothold in humans, a critically important step in the infection cycle. In general, coronaviruses can potently antagonize antiviral innate immunity by interfering with both interferon production and the cellular antiviral subsequent response. For instance, it was shown in the mouse coronavirus and MERS-CoV have accessory proteins that block the interferon response pathway that degrades the viral RNA by certain oligoadenylate synthetase and ribonuclease. And a better understanding of the precise functions of the SARS-CoV-2 accessory proteins, especially their interaction with innate immune pathways, could lead to further antiviral drugs that may successfully promote the innate immune response. But this is in the future. The finding that SARS-CoV-2 was more sensitive to interferon than SARS-CoV, the previous virus, raises hope that giving interferon or interferon inducers very early in the infection could be beneficial and perhaps less likely to cause harm than using interferon later in the COVID-19. What I'm trying to say is that if you start interferon or interferon inducer early in the disease, this is more successful. And there are countries that are already using the interferon actually in the treatment of the COVID-19, and we'll be talking about the treatment protocols in the third lecture, I believe. SARS-CoV-2 and also MERS-CoV, Middle East respiratory syndrome virus, sometimes induce the production of double membrane vesicles that lack PRRS and continue their replication in the vesicle. Hence, the host body and host could neither detect it nor develop antibodies against it. So this is the problem. The viral particles sometimes they treat the immune system. Subsequently, in the immune response, what happens, the viral nucleotides through the toll-like receptor, which is the receptor in the immune system, in the endosome, and the viral RNA receptor retinoic acid inducible gene 1 or RIG1, and cytosolic receptor melanoma differentiation associated gene 5 or MDA5, and nucleotide transferase cyclic GMP AMP synthase are all responsible for the recognition of viral RNA and the DNA in the cytoplasm. These complex signals recruit adapters, including toll interleukin-1 receptor TIR domain, containing adapter proteins, including interferon beta, TIR domain containing adapter-inducing interferon B or TRIF, mitochondrial antiviral signaling protein or MAVS, and stimulator of interferon genes, proteins STING to trigger the downstream cascades molecule C. How complex is the response inside the cell to the viral invasion? Hopefully these responses are to eliminate the virus or to eliminate the infection. Then involvement of adapter molecule MYD88 can lead to the activation of the transcription factors such as nuclear factor KB and FKP, interferon regulatory factor 3 or IRF3, production of type 1 interferon, interferon A beta, and series of pro-inflammatory cytokines. Hence, virus cell interactions produce diverse set of immune mediators against the invading virus. All of these are protective mechanisms. I will try now to show the animation. Let us watch the video together. Now I hopefully will enable to share also sound in this video. Let me open the YouTube video just in a minute. And this hopefully will show you the pathogenesis of the COVID-19 better.
For just $67, you can make as many videos as you want.
Okay, I'll skip the ad. There's an ad in the beginning. Okay, skip it. Hopefully you can hear the sound. This is the structure of the protein with RNA, genetic material, the 4 major proteins that we know already. And this is the large spike protein, which is responsible for the attachment and entry of the virus. The virus spreads through the air and droplets. And then through the spike protein, we have the attachment to the target or receptor, which is the ACE2 protein on the surface of the cell, human cell. Then recognition. And then with the help of the fusion protein, fusion with the membrane of the target cell. And then endocytosis, as you can see in the images. And then the penetration of the RNA material to the cytoplasm. And then the cell recognizes the RNA as its own. And we have the translation of the viral proteins in the ribosomes, and the generation of the new RNA molecules as well, packaging of new viruses, the 4 consisting of the RNA and surrounding proteins, and then the process of the exocytosis, as you could see, and reinfection of the new cells. And the whole cycle is repeated again. The infected cell releases many viral particles to the surrounding cells. Okay. So going back to our slideshow, I would like now to talk about the current state of the COVID-19 worldwide. As per July 12, which was 1 week ago, we had about around, let us say, 400,000 new cases, and total confirmed cases was almost 200 million. And 4 million deaths were registered. This is worldwide. And as we already said, this started in December 2019 in Wuhan, China, when pneumonia-like disease was. And the throat swab of the infected person was diagnosed by the CDC, which is the Center for the Disease Control and Prevention in the United States of America. And then the causative agent was termed as 2019 nCoV, coronavirus, by the World Health Organization, or WHO, in January 2020. The disease caused by the agent was termed as COVID-19 on February 2020, and COVID-19 has been characterized as a pandemic by the Director General of the World Health Organization on March 11, 2020. And since that, we have a pandemic. And we see already from the video how the virus is transmitted. It is released in the respiratory secretions, for example, during coughing, sneezing, talking. Very invasive are procedures when the doctors are exposed during the endotracheal intubation and extubation. Large number of viruses is released from the patient to the doctor. That's why they wear special protective personal equipment. This infection occurs when the other individuals have deposited on their mucous membranes. The problem with this new coronavirus is that it persists on surfaces for varying durations and degrees of infectivity. Although this is not believed to be the main route of transmission, but for example, on the plastic or on the paper surfaces, the virus can survive for up to 72 hours or even more, decreasing. Although, as I said, the infectivity is decreasing over time, but still, for several days, potentially we can be infected if we touch these surfaces containing the virus.
People of any age may be at high risk if
regarding the infectivity of the person who has the COVID-19 infection, the duration of viral shedding varies significantly and may depend actually on the severity of the patient's disease. And there was a study on 137 survivors of COVID-19 that showed that viral shedding based on testing of oropharyngeal samples ranged from 8 to 37 days with a median of 20 days. But it varies, as I said, a lot. So these findings were incorporated into the CDC guidance on the duration of the isolation following the COVID-19 infection. Additionally, patients with profound immunosuppression, for example, people who had bone marrow transplantation, or we call it hematopoietic stem cell transplantation, those who receive cellular therapies for their autoimmune diseases may shed viable viral particles for at least 2 months, which is much, much longer than the person with normal immunity. The SARS-CoV-2 has been found in the semen of men with acute infection, as well as in some male patients who have recovered. So this is a recent information. Could be potentially transmitted through the semen. It is investigated currently. Approximately, as you know, approximately 40 to 45% of SARS-CoV-2 infections are asymptomatic. And it was shown that 59% of all transmission came from asymptomatic persons, comprising 35% from pre-symptomatic individuals and 24% from individuals who never developed symptoms. Here I have to note that we have people who are called pre-symptomatic. Pre-symptomatic people are people who currently don't have the symptoms, but later on they become symptomatic. And people who are truly asymptomatic are those who never develop symptoms. So 24% asymptomatic, 35% were symptomatic, those who transmitted the disease to the others. About the mutations, I will talk in details after the break, but now briefly, we have several variants with the mutations, and I will talk about only mutations that are of concern because either they are more infective or spread more quickly, these viruses with the mutations, or they cause more severe disease. More commonly, we call these mutations using the Greek letters. So we all heard about the alpha mutations that were described in the United Kingdom, or also we know it as B117. And all of us heard about the Beta South Africa mutation, also known as B1351. Also Gamma Brazil, which is P1 mutation, and Iota, which was described in the New York City, called B1-526 and B1-526B. So what are the characteristics of these new mutations? Why they are mutations of the concern? For example, with the alpha UK virus, there was increased viral load. And here we can see that we have single mutation in the virus that resulted in that. Another mutation, also in the alpha UK virus, resulted in the increased ACE binding. While when we are talking about the beta, gamma, and iota viruses, we have a different mutation, E484K, that increased both transmission and virulence and decreased, unfortunately, the neutralization by the vaccines and monoclonal antibodies. And when combined with other mutations, they may result in an escape mutation, the escape from the treatment. The next mutations are called Epsilon, California. We know it as California. And particularly of concern is the Delta, which was first described in the Indian continent or Indian territory. It is B1617 lineage and its sublineages. What are the characteristics of this mutation? That monoclonal antibodies may be also less effective. And one of the first documented mutations in the US after being initially circulating in Europe is the mutation D614G with increased transmission, and it is included in nearly all variants of interest and variants of concern. What are these definitions of the variants? We will describe further. It is important to understand for us as healthcare professionals who are people at particular risk for COVID-19. According to the CDC, which is Center for Disease Control and Prevention, individuals at risk, high risk for infection include persons in the areas with ongoing local transmission. We can consider ourselves now at risk because we are in such area. Healthcare workers caring for patients with COVID-19, close contacts of infected persons, and travelers returning from locations where local spread has been reported. For example, if we are returning from current place where we are to the territory which is almost free of virus or has very few cases of COVID-19, then we will be also regarded as persons at risk until we undergo quarantine. And also certain comorbidities carry significant association with risk for severe disease. These people are, so don't confuse, please. These are people who are at risk for COVID-19 in general, and these are people who are at risk to have severe disease. Who are they? Cancer patients, cerebrovascular disease, chronic kidney disease, chronic obstructive pulmonary disease, diabetes mellitus, both type 1 and 2, heart conditions such as heart failure, coronary artery disease, cardiomyopathies, immunocompromised state, for example, after solid organ transplantation, obesity, which is regarded as a body mass index 30 kilogram per square meter or greater, pregnancy, smoking, either current or former. And there are comorbidities that have less clear association with the risk of severe COVID-19 illness. Children with certain underlying conditions, Down syndrome, human immunodeficiency virus, neurological conditions including dementia, overweight, so C. Clear obesity is a clear risk factor. Overweight is a potential risk factor to have severe disease as well. Overweight is defined as body mass index 25 to less than 30 kilogram per square meter. Other lung diseases, including interstitial lung disease, pulmonary fibrosis, pulmonary hypertension, sickle cell disease, solid organ or blood stem cell transplantation, substance use disorders because they share the syringes and other paraphernalia which are transmitting the disease. Among the substance users, use of corticosteroids, or other immunosuppression, cystic fibrosis, thalassemia, asthma, hypertension, immune deficiencies, and liver disease. Why should we know these people are who are at risk or potential risk? Because these people should be vaccinated as a primary, as the first priority. I believe we have to make a 5-minute break. Now it is 9:46, and at 9:51 we'll continue our lecture. I will mute myself meanwhile.
The coronavirus, COVID-19. He's been infected. He goes around other people. He's in the same room with a bunch of people, okay? If he happens to sneeze or cough and he spreads those respiratory droplets that could be airborne, and they somehow get into the mucous membranes of people nearby, how many could he potentially infect? They say that he can infect 3 people. So therefore, the R0 of COVID-19 has actually been said to be anywhere from 2 to 3, could even be higher. We'll talk about that in just a little bit, what I mean by that. So again, what's the R0 for COVID-19? We believe it to be anywhere from 2 to 3. Let's take the worst case scenario and say it's 3. Okay, 1 person can infect 3 people, right? So you start off with 1 person. That infects 3 people. These 3 people, each one infects 3 more people. That gives us 9 patients now infected with COVID-19. Now these 9 people can go and infect 3 people each. How many is that? 27. So you can see how this is an exponential rise. If we look at this on a graph, when we look at R0 of COVID-19, let's do it here in blue. If you look here at R0 on the y-axis, what are you going to see? You're going to see this number, it's going to increase, right? It's going to be exponential. This is an exponential growth. If we compare the R0 of influenza, which is around 1.3 approximately, let's just round it to 1 and say that 1 person has the ability to infect 1 other person. So if this person is infected with influenza, he's going to pass it on to 1 more person. That 1 person is going to pass it on to the next person, which is going to pass it on to the next person, right? So you
Hello guys again. I hope you enjoyed the first part of our lecture. For those who are not able to connect to our translation, Zoom have a limitation for 100 participants. We organize the online translation to Facebook, VK, YouTube of our SMU press team. So please share this information with guys to give them opportunity to watch this lecture and to enjoy the lecture, because unfortunately this limitation to 100 participants is present right now, and we cannot fix this right now.
currently, right now, you can see R0 is greater
What?
than exponential growth. In comparison to something like flu.
Илья Рафаэльевна, вы будете продолжать, да, мне убираться?
Да, я через 2 минуты, я им сказал, я буду продолжать.
Все, я покидаю.
Спасибо.
Rate of transmission or the degree of spreadability, but there's
We have
also
still 2 minutes as I
this is called
announced the
interval.
5-minute break.
Is referred to as the series.
We will resume at 9:51.
Like very simple way of describing this. And let's say here's patient 1, okay? Patient 1 develops symptoms, okay? And let's say from the day 0 that he develops symptoms all the way until day 14. Okay, let's say that he has symptoms for 14 days. So this is when the symptoms stop. This is when the symptoms start. Let's say that somewhere during his period of infection, he spreads that virus to another person. So let's call this X2, right? Here's X1, patient 1, patient 2. This person gets infected, let's say somewhere.
Can you see me on the video?
Right, maybe it's day 2, okay? Maybe day 2, somehow around that time, this actual patient, patient 1, comes into contact with patient 2.
Dear students, can you see me on the video?
Their symptoms start. So now we're at
Yes or no?
0, and let's say that they go through a 14-day period.
Yes, everything is okay, Илья Рафаэльевна. You are audible and seen perfectly.
Excellent. Thank you very much, because I cannot see myself. Okay. Then I will go on. We have a small part left regarding the introduction.
A lot better, less risk of this becoming such a high speed of transmission. So what is the series interval for COVID-19? It actually depends. It depends on which source you're looking at. Some say that it's anywhere from 5, and some will say anywhere from 7.
Now I'm unmuted. You can hear me again, right?
Influenza, for example, it's actually approximately
Okay, I will overview now the signs and symptoms of COVID-19. As you know from your surrounding people, or might be some of you have got the infection, unfortunately. In the past, the presentations of COVID-19 range from asymptomatic totally to mild, to moderate, and in some cases severe illness and even mortality. Symptoms may develop 2 days to 2 weeks after.
Small amount of time. So imagine here, within one person infecting 3, it took 7.5 days. From
I will unmute myself again.
From 9 to 27, it's 7.5
Okay.
days.
Average 5 days for the development of symptoms, ranging between 2 days and 2 weeks.
If you were to imagine,
And among them, all cases in the studies, 81% were mild, fortunately. Majority are mild, either absent or mild pneumonia. This is the definition of the mild infection.
we got to be at least
14% were severe, which is regarded as hypoxia, dyspnea, or shortness of breath. Hypoxia is deficiency of oxygen in the body, measured as oxygen saturation, and more than 50% lung involvement within 24 to 48 hours. 5% were critical with shock, respiratory failure, multi-organ dysfunction, and the worldwide data are showing the average mortality is 2.3%. 2.3% were fatal, and this varies from country to another, depending on the maybe ethnicity, depending on the healthcare facilities, and some other factors. What are the most common symptoms described by the patients with COVID-19? Fever or chills, cough, shortness of breath, or dyspnea, as we said, or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, diarrhea. Now with Delta virus, they say that we have more abdominal symptoms than previously. Sputum production, malaise, respiratory distress, neurological findings such as headache, altered mentality, headache is repeated, and the most common serious manifestation of COVID-19 appears to be pneumonia. The diagnosis is based on the laboratory data and on the history. It should be considered if you have a patient with respiratory tract symptoms, those that we have described in the previous slide, and newly onset fever, or in patients with severe lower respiratory tract symptoms with no clear cause. Suspicion is increased if such patients have been in an area with community transmission of SARS-CoV-2 or have been in close contact with an individual with confirmed or suspected COVID-19 in the preceding 14 days. This is the average day for transmission, period for transmission. A definite diagnosis is based on the microbiologic testing, actually PCR, which stands for the polymerase chain reaction, or now in many countries we have the home antigen-based testing, rapid antigen test. Of course, a rapid antigen test does not give the final result, but at least it allows us to screen for the positive cases. Patients who do not require emergency care are encouraged to contact their healthcare provider over the phone and not go to the healthcare facilities. They have to call the doctor to their home. And patients with suspected COVID-19 who present to a healthcare facility should prompt infection control measures. For example, in Russia, as you know, there are special compartments or special boxes for the examination of the patients with fever with all precautions. So this stream of patients is separated from the usual stream of patients, and they should be evaluated in a private room, as I said, with the door closed. Ideal is to have the airborne infection isolation room and asked to wear a surgical mask. General and non-specific laboratory findings that may be seen in the COVID-19 patients are leukopenia, which is decreased leukocyte count, leukocytosis, which is the opposite, increase in the leukocyte count, and lymphopenia, which is isolated decrease in the lymphocyte count. They were common among the early cases. Commonly elevated are lactate dehydrogenase enzyme and ferritin level. As you know, ferritin is a non-specific reactant showing the inflammation in the body. And among patients with COVID-19 who were hospitalized, the older age, the neutrophilia, and elevated lactate dehydrogenase, as well as D-dimer level, this is the one of the coagulation tests, increased the risk of acute respiratory distress syndrome, which is the severe complication of COVID-19, and death. The chest computer tomography in patients with COVID-19 is also helpful. And the specific features in the CT scan are the peripheral distribution. Unfortunately, I did not bring the CT scan. The CT scan of the COVID-19 patient.
And it's going to be making a bunch of different stuff, right? Now, from here, after it synthesizes these proteins, guess what else it can do?
Just let us open this image, for example. No, unfortunately. Another attempt. Sorry. This one. We can see peripheral distribution of the specific lesions, which are called the ground glass opacity. So peripheral distribution is found in 80% of cases. Ground glass opacity. This is typical ground glass opacity, as if you have left a glass with water on the glass surface, and then after you remove the water, you can see this opacity on the surface. So this is characteristic not only for the COVID-19 pneumonia, but also for other viral pneumonias. But combination of several findings, such as peripheral distribution, ground glass opacity, fine reticular opacity, vascular thickening, and less common features, including central and peripheral distribution, which is in minority of cases, pleural effusion, lymphadenopathy. When the combination of the common findings is present, this is highly suggestive of COVID-19. Why that COVID-19 can be a severe disease? Because we have characteristic complications. Approximately 5% of patients with COVID-19 and 20% of those hospitalized experience severe symptoms that necessitate their stay in the intensive care unit. They include pneumonia in 70% of severe cases, acute respiratory distress syndrome or ARDS in 15% of cases, acute kidney injury in 90% of cases, and acute liver injury in 19% of cases. Cardiac injury, is being increasingly noted, including troponin elevation, acute heart failure, dysrhythmias, and myocarditis. And this is very essential to remember because some anti-vaccinists, when they are talking about the certain vaccines, for example, recently Pfizer vaccine has been described to cause myocarditis in very isolated, very rare cases. You have to remember that the cardiac injury is caused by the virus itself in a much higher number of cases. So we have the damage to the myocardium with resulting acute heart failure. 10 to 25% of hospitalized COVID-19 patients experienced prothrombotic coagulopathy, and this is a very, very serious event. Maybe you have watched on the TV that in Moscow, there is a specialized hospital who are dealing with the amputation of the extremities for COVID-19 patients because these patients sometimes they do not recognize that they have severe disease. They do not seek the medical attention while having pain in their extremities and ischemia. And then this severe ischemia may result in the necrosis of the extremity and amputation. Not only the amputation of the extremities, we have the resulting myocardial infarction, cerebral strokes, pulmonary embolisms, and other prothrombotic coagulopathy complications. So different venous thrombosis and arterial thrombosis take place. And that's why after recognizing this complication, one of the essential parts of this treatment protocols is to give the anticoagulant drugs, at least in severe cases of COVID-19. Unfortunately, neurologic manifestations include impaired consciousness, stroke. Stroke is actually, strictly saying, is the thromboembolic complication, but also other neurological features have been found. Probably you have talked to these people, they have confusion, they have fogginess of their brain, as if they are thinking through the fog, you know, not clear mentation. And this can be followed by the post-COVID syndrome. People, even with mild to moderate infection, are cured from COVID-19, but these neurological manifestations may last for several months. And the working capacity or ability to think, to operate machinery or other accurate tasks cannot be performed by these people. So this is a really serious problem. It may result in invalidization of the population if we do not fight this infection promptly. So this next slide shows this post-COVID-19 or post-acute sequelae of COVID-19 infections. Although the majority fortunately recover fully, but those that do not report the following symptoms: fatigue, dyspnea, and this is because the significant proportion of the lung has been destroyed by the disease, by the pneumonia. When the pneumonia is widespread and then it causes the fibrosis, then there is limited capacity for the oxygenation of the body. That's why the continuous fatigue and dyspnea. Cough may be persisting, anxiety, depression, insomnia, inability to focus, which is, as I told you, defined by these people as brain fog, gastrointestinal problems, sleep difficulties, joint pain, chest pain. Some people report inability to smell or taste for several weeks or even months. So all these symptoms last for months after the acute illness. And this post-acute sequela of SARS-CoV-2 is abbreviated as PASC. And now it is a special term for what is commonly called long COVID or long haulers. If these symptoms persist for more than 12 weeks, this is defined as PASC, post-acute sequela of disease. Management. Of course, there will be a special lecture about the management, but now I will mention very broadly the management approaches to the COVID-19. And these treatment protocols, of course, they vary from one country to another. The United States differ from Europe, Russia differs from India or Japan, and so on. But what is in common is that, of course, these treatments, they have received the emergency use authorization. Some new treatments appear, as you know from pharmacology, those of you who have studied pharmacology, the development of the drugs is a very long process. But in this emergency situation, which is the current pandemic, we cannot wait for the permissions to introduce the drug into the clinical practice. That's why the process of the drug development in this case is very abbreviated, and the drug receives the emergency use authorization. For example, in the US, this is abbreviated as EUA program. This allows for rapid deployment of potential therapies for investigation. So investigation is very short, and investigational therapies are introduced very, very rapidly, as I said, with emerging evidence after we receive the evidence from these clinical trials or investigations. For example, one of the breakthrough treatments was the remdesivir. On October 22nd, 2020, remdesivir, which is an antiviral drug, it was the first drug-specific antiviral approved for the treatment of COVID-19. What is the place of the remdesivir? First of all, it is a very expensive drug. Secondly, it can be given only intravenously. It does not exist for the oral use. That's why it is indicated for the treatment only of hospitalized patients, adults with COVID-19 disease, and also children aged 12 years and older whose weight reached at least 40 kilograms. For the children younger than 12 years who weigh at least 3.5 kilograms, there is emergency use authorization yet to treat with remdesivir. What I'm saying that it is approved, fully approved for the adults and children aged 12 years and above who reached this weight, but children below this, they might receive the remdesivir under the emergency use authorization. It is not used widely. Also, the emergency use authorization has been received for vaccines, and we have different vaccines in different countries. And I will have a special lecture. The next lecture will be devoted entirely to the vaccines. And also, fortunately, now there are monoclonal directed antibodies against spike protein. And also many countries received the authorization to use the convalescent plasma, which means that the patients who have recovered from COVID-19 provide their blood, and the plasma is isolated, and then this plasma that contains the antibodies against the coronavirus, is transfused to the sick people, usually with severe disease. And next treatment is the baricitinib, which is the JAK kinase inhibitor. And we have discussed already the importance of this pathway, and we'll discuss this further as one of the pathways involved in the interferon signaling process. And another successful treatment is the tocilizumab. And fortunately, the tocilizumab existed already in the market. It is one of the treatments for the rheumatoid arthritis, as you probably know. And tocilizumab is the interleukin-6 inhibitor. And interleukin-6 is involved not only in the rheumatoid arthritis, but also in the COVID-19, one of the major cytokines causing the cytokine storm. So using tocilizumab has dramatically changed the prognosis of the patients with severe COVID-19. So these are treatments that received emergency use authorization in the United States, but different other treatments received authorization in the other countries, including Russia, and I will be talking about that while we'll be discussing the different protocols, as I said. One of the game-changing treatments was in the beginning of the pandemics. Probably you remember in the early spring of 2020, when the dexamethasone, one of the corticosteroids, has been introduced for the patients with a cytokine storm, and it has dramatically improved survival in such hospitalized patients with severe disease who required supplemental oxygen. And the greatest benefit was shown for dexamethasone in those who required mechanical ventilation. Other treatments are specific anti-infective therapy. If we notice that there is bacterial complication, we give specific antibacterial drug, or when the patient was already on broad spectrum antibiotics, they develop another complication, which is fungal infections, and they might need to receive the antifungal drugs. Of course, supportive care, including the oxygen, as we mentioned, is used widely, and support of the vital organ functions in severe cases when the mechanical ventilation is not effective. Sometimes the ECMO is used. ECMO stands for the extracorporeal membrane oxygenation, which actually treats both the acute, the compensated heart failure and acute respiratory failure, where we have the multi-organ dysfunction. Sepsis is one of the complications, and this is treated by antibiotics, as I said. So these are the major approaches for the treatment, very, very broadly. And now I will talk in the remaining time of today's lecture. I will be talking about the variants or mutants of the COVID-2 virus. They are tracked by the special, organizations or institutions, and this is because all viruses, not only the SARS-CoV-2, but also other viruses, they change over the time. And fortunately, most of these changes have little or no impact on the virus properties. However, some of these changes may affect the virus properties, such as what is important for us, how easily it spreads, how more severe the disease becomes, or whether the virus will become resistant to the current vaccines and medicines, and it may even escape the diagnostic tools, or maybe it will be resistant to other public health and social measures. That's why we track these new variants of the viruses. Actually, during the late 2020, the emergence of the variants that posed an increased risk to global public health prompted the characterization of specific variants of interest. So please note this abbreviation stands for variants of interest, VOIs. And also we have the variants of concern, VOCs. So we track them, as I said, and characterize these new variants or mutants in order to decide what global monitoring and research is necessary, and ultimately what should be the response or measures to limit the pandemic. Of course, the WHO, which is the World Health Organization, and its international networks of experts are monitoring changes to the virus so that if significant amino acid substitutions are identified, as we could see in one of the tables that I was showing to you briefly with the new mutants. So any significant amino acid substitution, if occurs, they inform countries and the public about any changes that may be needed to respond to the variant. Maybe vaccine should be changed, maybe treatment is changed. We all heard that now in Russia, the treatment protocol is being modified, and very, very soon on these days, we'll have the new treatment protocol because of the predominant prevalence of the Delta mutant that came from India. Now it is predominant in many, many countries, including Russia. So how these SARS-CoV-2 variants are classified or named? the established nomenclature systems for naming and tracking these genetic lineages or mutants of the virus are several. We have GSAID, we have next strain and Pango systems, and they are currently in use by scientists and by scientific research. But for the simplicity, the expert group convened by the WHO has recommended using Greek letters, those that we hear: alpha, beta, gamma, delta, and now we have the epsilon and iota, as we could see in the table as well. So, as I said, we have the variants of concern and we have the variants of interest. What are these definitions? Variants of concern, VOC, are SARS-CoV-2 variants that meet the definition of variant of interest. We'll see below. Let us define them, the variant of interest. Let us first define the variant of interest, VOV, in order to understand the variant of interest. Variant of interest is a variant with genetic changes that are predicted or known to affect virus characteristics, such as: what do we care about? How transmissible is the virus? How severe the disease will be? Whether it can, the virus will escape the immune response? Whether it will escape diagnostic tests or therapeutic, including the vaccines? And identified to cause significant community transmission or multiple COVID-19 clusters in multiple countries with increasing relative prevalence alongside increasing number of cases over time, or other apparent epidemiological impacts to suggest an emerging risk to global public health. What did we say? What among the thousands of new mutants, what is of our interest? We have the genetic change that will change the important properties of the virus, and they are quite spread in multiple countries. This is very simple. Now, we need to go back to the slide about the variants of concern, VOC. These are variants that meet the definition of the variant of interest, those that we have just mentioned, and through a comparative assessment has been demonstrated to be associated with one or more of the following changes at a degree of global public health. So these are more serious, more threatening than VOIs. What are these properties? Increase in transmissibility or detrimental change in COVID-19 epidemiology. This is what we are experiencing with Delta virus. Or increase in virulence or change in clinical disease presentation, or decrease in effectiveness of public health and social measures, or available diagnostics, vaccines, or therapeutics. So this is something more serious than the VOE, because it has the global significance, global public health significance. Examples of variants of concern: alpha, Pango lineages B117. As I told you earlier, it has originated in the United Kingdom in September 2020. Beta, several lineages. The primary one is the B1351, and the origin is South Africa in May 2020. Please note that we have the additional amino acid changes monitored, in addition to the next strain plate. Gamma appeared in Brazil in November 2020. It is called P1, P11, P12, and unfortunately, currently troublesome Delta, which is B1617. 2, and also AY1, AY2, and these are the major. Now, the variants of interest, we have defined them. They are just predict or known to affect the virus characteristics, and they have clustering in multiple countries. And the examples of these variants of interest variants of interest or VOIs are ETA, that are defined by Pango lineages as B1-525, appeared in multiple countries in December 2020. Iota, B1-526, originating in the US in November 2020, and Kappa, B1-617-1 from India in October 2020, and Lambda. Lambda is another troublesome. It might escape vaccines, but it is being investigated, and it originated in Peru in December 2020, known as C37 as well. I believe we are done for today. These are the references that I have used for today's lecture. Thank you for your listening. Maybe you have certain questions, please. We have about 20 minutes or so, 10 minutes or 15 minutes for your questions, please. Rasul Salihowicz, if you would like to give the opportunity for several questions, I am ready.
Okay, I think now I switched on all mics, and if students wish to ask.
Maybe it is better one by one. Do we have option that they raise their hand and then
I'm
do
not
we have
sure.
such?
I think they can raise hand or give an
actually, I don't see this option. Okay, we'll try one by one to give them opportunity. Okay. Please unmute their microphones.
Guys, please, do you have any questions regarding to this very important topic?
Is there anything not clear or you'd like to ask me for further information? Please, I am ready.
Maybe if they quite shy, we will make WhatsApp public and they will send me questions.
Right.
Next lecture, you will cover it.
Yes, sure. Any form of communication, you can write a text and then I will receive this text and I will prepare my answers for the next lecture. And I will see you after tomorrow, hopefully, and my second lecture will be about the COVID-19 vaccine.
Oh, very nice.
Thank you for listening.
Thank you.
And see you.
See you. Thank you.
Bye-bye.
Bye-bye. Guys, thank you very much for participation. It's very important for us and for university and for you as well. So see you tomorrow at 9 a.m. Our next lecturer will be a Chinese professor. So by the way, Naila Rafaelna, she is not very Russian, she is Jordan professor and she speaks very good Arabic. So Naila Rafaelna, also I would like to ask you to take part in work with our Arabic students from Egypt. Okay. Sometimes they are very tough.
No, they should not. They are very nice people and I'm sure we can find a common language.
That's nice. Maybe someday I also will be able to speak in Arabic.
Hopefully. All right.
So thank you very much. See you tomorrow.
See you. Bye-bye.
Bye-bye.